Good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for ACOexhibithall.com, and I'd like to welcome you all to today's panel discussion hosted by Curating, which is called Profiling ACO Success: What Drives High Performance in the Medicare Shared Savings Program. This is one of the highest attended, highest registered webinars we've ever done. So there's a lot of interest here, and we're super excited to have our panelists with us today. A couple notes before we get started here, some housekeeping stuff. Everyone's joined in listen-only mode today, so you don't have to, this isn't like Zoom, you don't have to worry about muting your mic. It's been done for you. And also the webinar is being recorded, so you'll have an opportunity to rewatch it afterwards and or share it with colleagues. And we hope you do. We hope you get as many people to watch as possible. So what I'm going to do is I'm going to, after the presentation, I will later on this afternoon send each of you everyone who's registered, even those who weren't able to attend, a link to the recording, also where you can download the slides. So you'll have access to the slides as well. Okay, and during the webinar, we want to hear from you. So please submit your questions. There's a question module in your little control panel there as an attendee. And so if you ask a question, you can do that at any time. You don't have to wait till the Q&A session to do that. Go ahead and submit it, and we'll get to as many of those as we can during the allotted session today. And then if for some reason we're not able to get to you, then we will make sure to follow up with you via email afterwards. So even if we're kind of wrapping up and closing out and you have a question, go ahead and submit it. We will get back to you. Okay, so let's dive in. I want to do a quick introduction to CareJourney. CareJourney is a leading provider of clinically relevant data analytics that help value-based organizations make better business decisions around network growth, provider performance, and care coordination. CareJourney works with over 100 leaders in the healthcare space across payers, providers, and life science companies, some of whom you will hear from today in the presentation. So we're very excited about that. CareJourney offers insights delivered from one of the largest claims data sets in the country that's covering over 200 million lives and over 2 million physicians. So that's huge. So at this time, what I wanted to do is to introduce our moderator, who's Dr. Catherine Schneider. And she's the CEO of Two Canoes Health and a CareJourney advisor. And she's going to kick us off, and she will do the more in-depth introductions of our other panelists today. So welcome, Dr. Schneider.
Thank you so much, Garrett, and thanks CareJourney for inviting me to moderate this awesome panel. And I'm glad we have such a great registration list. I've seen a lot of the names and a lot of old friends and colleagues on that, so happy to see you here today virtually. A little bit about me. I'm coming off of a year as a nomad in an Airstream all over the country, which was planned pre-pandemic, and you'll just have to read the forthcoming book about those adventures. But most of you know me as the previous CEO of Delaware Valley Accountable Care Organization in the greater Philadelphia region, which was one of the largest ACOs in the country, joint venture of two health systems. What you might not know about me is that I go back in this space about 20 years. I ran one of what was then called Medicare's physician group practice demonstration projects back out of Middletown, Connecticut 2 decades ago. And so I have had the pleasure of watching this program, the Medicare Shared Savings Program, and related programs like NextGen, which we'll be talking a little bit about today as well. I've had the pleasure of seeing them evolve over the years and see a wide variety of organizations through my work as chairman of NACOS and with a software company previously as well. The strategies that have been in use to actually change the care model, to use data to do it. It's been so exciting to see this journey. And so go ahead, Garrett, to the next slide. What we hope to do today is really give you a theme discussion, fairly informal fireside chat, which I like to do. It's a little awkward doing it this way, but we've all learned over the past year. we want to touch on the themes of these foundations for success in value-based care. And again, this is a focus on the Medicare ACO programs, plural, not so much on Medicare Advantage, although obviously there is a lot of commonality, particularly in how the care model is applied, but there are some nuances. You don't have all the tools in the ACO programs that we do in Medicare Advantage. We're going to talk a little bit about really, building high value networks. How can you use data to do that? How do you engage your primary care physicians? How do you put the patient at the center of everything? And really, what is care coordination? So what I like to do, having done this work for 2 decades, sometimes we get into like ACO techno babble, and I like to take it back to a value story at the top of every meeting that I have. And a value story, it's just a little stolen from the hospital quality or safety story. It's just a snippet of a very real world impact that we have had on either a patient or possibly on a practice or provider through the work and the infrastructure that's been put in place through this value-based care model. It's different from fee-for-service. So these are outcomes that would not have happened under the traditional fee-for-service model. And I know we've got some great stories here today. And so we're going to kick off today by hearing value stories from each of our each of our panelists. Garrett, if you could go to the next slide, we'll keep this up as we do our value stories. This is in alphabetical order. Our first story will come from our panelist, Rachel Corbett, who's the Executive Director of Primary Care Alliance, which is Aegis Medical Group and the Primary Care Alliance ACO in Florida. Some interesting nuances to their model. But Rachel, I'm going to turn it over to you now for your value story and anything else we should know about your organization.
Hi there, thank you. Welcome everybody. My value story is about a patient that just recently we actually were able to help. We're with the next generation ACO, we're able to build a preferred provider network. So we have contracts with a number of specialists, home health, skilled nursing facilities. And so we had a patient that came into one of our offices and needed some IV Lasix, normally twice a day, and normally would have had to send them to a hospital or a skilled nursing facility, but due to our partnership with a home health clinic or home health agency, we were able to send the patient back to their house nice and comfortable and have the home health go out twice a day, unlike most home health who hate to go even once a day. But we're able to really get that patient the care they needed in the appropriate setting and actually avoid an admission. And so it just helped the patient, get the care they needed.
Okay, that's a great story. Bravo. It really illustrates to me what a care model is and how a care model can be different, right? Different use of people, process, and technology to really deliver on an outcome that is, quadruple aim. Everyone's happy: the patient, the wallet, the quality, and the provider, and their quality of life as well. Next, I'm going to turn it over to Rick Forster, who is the Senior Vice President of Value-Based Operations for Privia Health, which very exciting. You may have seen in the news that Privia went public, I think back in April, and Privia is a large multi-state aggregator of primarily primary care practices, and has been very successful in not just the Medicare MSSP ACO, but other arrangements as well. So Rick, tell us your Privia value story.
Sure, thank you, Dr. Schneider. And unfortunately, I don't have an upcoming book about my travels in the Airstream, but maybe someday. But happy to be joining today. You gave a great intro on Privia, so thank you for that. I think these numbers are a little outdated, but we have over 700,000 attributed lives, including Medicare Shared Savings Program, Medicare Advantage, commercial, Medicaid. And so we've got a lot of experience in that MSSP space, so very timely topic today. But as I was going through different examples of patient stories, I think the one really resonated with me for today was a great example of independent doctor practices who are not normally affiliated working together under a common ACO umbrella. So we had an instance where a high-risk patient called their care center with some acute symptoms, but it was a very small practice, and their schedule was booked, and they couldn't see the patient fast enough. So what happens normally in these circumstances is go to the ER, right? Instead, the practice forwarded the call to our nurse triage line. Privia has a 24/7 nurse triage line that our nurse team was able to quickly assess the patient and then reroute the patient to a nearby other Privia practice, again, another independent group that could see them within the hour. That practice had the full record, health history, notes, everything, so there's no kind of exchange. And we were able to get a stat x-ray of the patient. They were able to see one of the top pulmonologists in the region within the hour, and ultimately avoided any unnecessary care, got the patient the care they needed in a very timely way. So I thought this was just a great example of sometimes independent practices don't work as well together, or don't necessarily have the supplemental resources when their patients need that type of care. And so not only call it a Privia, but even just each other practices in the region can really provide that support network for our patients in the community.
Rick, that's a great story. And it's actually maybe the first time I've actually ever heard of an independent primary care practice calling on a sister independent practice in order to, you know, fill in the gaps like that. I've heard about doing it like to a specialist, or, you know, maybe within a multi-specialty practice, different sites. But I love that story. That just goes to show how, you know, there are many ways that you can create a cooperative, well-coordinated, seamless continuum of care to serve our patients better, which is really what this is all about. I love that story, so thank you for that. Okay, now turning it over to John Ford for his value story and introduction. John is CEO of Prime Care Managers, which manages practices in North Texas and Southern Arkansas, and they are a successful ACO model. But John, tell us anything else we need to know about you and your value story, which I did get a preview of, and I love that one too.
Thank you. Yes, so more of a community-based model, regional, trying to go deep and go wide, trying to reinvent the delivery into an outpatient in IDS model. So not hospital-based, independent primary and multi-specialty. We've been able to wrap our management structure and our data analytics in-house around this, combined with a lot of comprehensive continuum of care through fully integrated home care, fully integrated hospice, outpatient rehab. So we've really stretched the reach of our primary care physicians in their service area. So we're very pop health based, very outside in based. And we've been successful. We've continued to move up the ladder pretty significantly over the last couple of years. Looks like we're going to have another great performance year. So all happy. Love the community models. Love the independent primary care models.
And tell us your value story. Yes.
So an early hitter, in case you're one of those ACOs that's new to the game. Go check your ED frequent flyer list and start working down. You'll probably be shocked the first time you look at it, people that frequent the ED every week. So, you know, if that's a $2,000, $2,500 encounter, it's an easy score if you can try to get those frequent flyers down. We worked with one patient early on. He had 73 encounters in 1 year. Our virtual care team, we had our care management people reach out to him and build a relationship, get to know about what it was that was causing it. And he was getting frequent migraines, headaches, he was overheating. So we walked him through how to take cool baths and how to notice his symptoms as they onset. And we got him down into the low teens in the next year. So, you know, that right there on one patient was, you know, probably worth $20,000 in savings just through a virtual interaction.
And John, did I hear you right? This was a patient who'd been seen 73 times in the emergency department in 1 year.
In 1 year.
Yeah, right. So something is broken with the system when that has to happen. So great job. And just showing, again, what this wraparound can really do for a patient. So 3 great stories. Thank you so much, guys, for that. Garrett, I think we can move off the slides now and get into a little more conversation. So I'm going to start with Rick. Rick's Privia's a Care Journey client, so I know a little bit more in depth about the tools that you've been using. Let's talk about curating a network. When all this work started, it was so primary care centric. And certainly you want to be able, as you build an ACO, to pick good primary care physicians to form that foundation of your ACO. But I think as we matured in this industry, we really understood that so much of the spend comes from, post-acute and from specialists. And how do you, especially when you don't have good levers on benefit design, like in Medicare Advantage, where you can just, like a health plan, say, like, here's in and out of network, how do you sort of pick and curate that high value network of non-primary care, or if you want to talk about primary care, you can do that too. But I think everyone's really struggling with sort of the spend outside of primary care, and how do you either lift the tide, to like raise the tide to lift all the boats, or pick the boats that you want in the party. So tell us a little bit about that journey.
Yeah, it's a great question. And, I think a lot of times too, you mentioned benefit design, it requires starting first with great access to the primary care physician, because if the primary care physician doesn't have any sort of influence or impact in terms of where the patient goes, and it's an open access product like Original Medicare, then you can't necessarily get to the patient to the right place. So it starts with, really great access. And then, we look at what we call curating a virtual narrow network of preferred providers where we want our patients to go to, where we believe that they are the highest value. And the way we do that is really 2 main ways. The first way is we will collect outside third-party data. Care Journey could be a source, but payer data, there's other data sources that we acquire, and we look at, based off that data, what is it telling us in terms of the cost, and less frequently the quality that I think has an opportunity for improvement, to really understand, what are those sort of third-party perspectives telling us in terms of the value of specialists. We then take that, and the second part is, and I think this is really critical, is we take it to our providers for clinical input. We do not just trust the data because the payer said so. We think that it's very, very important to bring it to our providers and get them to review that data, offer any other input that they may have had working with the specialist. There might be nuances that are not necessarily present in the data, or the data might not be exactly correct. You can't just trust the data. So we feel like this combination of clinical input plus data creates what we call a preferred ranking, and we will tier our network in terms of top or bottom. You can kind of picture how that goes. And then we try and bring that network and decision making into the point of care. So when a provider is trying to select a cardiologist for that payer product, they know what they need to, they know who the preferred options are. And kind of all this is summed up by what we call trying to create a more informed referral. Privia, at least, is not in the game of really sort of heavy-handedly dictating what a clinician should do. I certainly don't want to have any stake in that. But we want providers really selecting our network and then having that data and input for them when they're going to make that selection. And so that's sort of one way. And of course, we've got to monitor all of that on the back end, right? To say, okay, we set up this preferred network, We have the tools and functions and workflows in order to refer those patients to it. But where do the patients really end up? And how do we just continue to iterate on that process overall?
Yeah, I love that term, like a more informed referral, because to your point, I mean, a lot of this data that we have is data that a lot of primary care physicians have never seen before at all. They may have sort of a gut feeling over, like this cardiologist always does this, whereas this one doesn't. But it's nice to be able to see that validated. I've gotten that feedback before when trying to do this kind of work. So it's sort of the data can shine some light on practice patterns.
Right.
It can actually change behavior of those specialists. Do you ever show the data to engage with the specialists, not just kind of to drive the referrals, but to actually change behavior?
Yeah, we do. We do try and bring that to specialists as much as we can. And, it's interesting, your kind of first point there. Not only do the primary care providers, usually have never seen this data, or it's in an inaccessible format, like say on a payer website or something like that, right? Not really usable. But also the specialists have never seen this data either. So, I think it's a lot about raising awareness. And so sometimes there might be an issue with the specialist tendency, but really nobody's ever come and talked to them about it. So, that's just where we're trying to bring data a little bit more forefront to the decision. Again, it's not everything. There's other considerations, but it's severely lacking in terms of just getting brought to the right parties over time. So that's what we try and do.
Yeah, that's great. Well, maybe your next value story, next time I talk to you, I want to hear one about how use of that data has actually driven, a big change in quality, cost, access. And to your point, I mean, it is one piece of the puzzle. So, you're not going, if a patient has a long-standing relationship with specialist X, you're not going, who's like 3 blocks from their house, you're not going to now refer them 100 miles away to specialist Y that they've never seen before, like that. But you don't have to be all or nothing to have success in this space, right? It's a tipping the balance, and it's starting to where there's an impactable decision to have that be a better informed decision. So I really like that approach that's not heavy-handed on either the providers or the patients. Rachel, we talked a little bit about sort of your network approach. Tell us a little bit more about that. And tell us also talk to me, we've talked earlier about like putting the patient at the center of all of this. So patient preference and giving the patient what they need. And how does being in this value-based model allow you to do that?
Yeah, so we had the ability with NextGen to create the preferred provider network, and we actually even went the next step to do the all-inclusive population-based payments, which is basically paying claims on behalf of CMS. And so we were able to get a contractual relationship with a lot of our preferred providers and be able to pay their claims on behalf of CMS. And so we used, similar to Rick, we used some data to see where are our patients going. They're already established with these specialists, and providers already have those potential relationships with the preferred providers or specialists. Where are the patients going? Really trying to keep it that patient focus of not change behavior of the patient necessarily, but let's work with the providers that our patients are already seeing. And so we went there, went out to specialists and different organizations to, hey, can you be a preferred provider? Can we pay your claims and start that contractual relationship with them, which was able to increase our coordination of care. Since the patient was already being seen there and had already established, we didn't have to change patterns too significantly. And so we were able to really get that specialist or preferred provider the understanding, to Rick's point as well, they never see data. They never, are discussed data. So getting that information to them to help the PCPs out and really be more coordinated with the care of the patient and ultimately keep the patient, in the best health possible. Or if they are sick, getting them the appropriate care when needed.
Yeah, Rachel, I'd be curious, just as a follow-up question on that, when you engage with some of these specialists that have been seeing the patients, I've often found the specialists, I mean, I guess it depends what market you're in. Often they just have, they do not understand sort of population health, managing total cost of care at all. And they think an ACO is like primary care docs getting their A1Cs on their diabetics, and that's all it is, and that it really has nothing to do with specialty care. So I've spent a lot of time trying to educate specialists. Tell me, like, what's your experience, Rachel, with when you go out to these folks? Can you help them understand? What do you tell them about like their role, other than just like, we're going to turn the faucet of referrals on or off based on whether, something is showing in the data?
Yeah, so we rarely, we actually try to stay away from guaranteed referrals. You always have patient choice with, straight Medicare, even with the next gen program. And so we try to not even bring up referrals in the conversations when contracting with a lot of the specialists. It does tend to come up from their side as they think they're going to have guaranteed referrals, which we can't guarantee that. But to your point, absolutely, most specialists do not understand how an ACO works, how value-based, whatever program you're in, whether it's a next-gen, MA, MSSP, anything along the lines of value-based, they don't understand. And so trying to get them to understand, it takes a lot of education, but ultimately it's like, what's in it for them? I mean, that's a lot of us is like, hey, what's in it for me? And really trying to get that over across to them, that it can create more value for the patients, more value for them as a practice, which then in turn, increases their referral stream. And so really trying to get down to the what's in it for me kind of thing. I know that might be too simplistic, but it really, kind of goes to their core of their business and trying to get understand how we can help each other. It's not a them versus us. It's a how can we help each other to make the patient care more optimal.
Yeah, and sometimes when you're able to show them what additional, like how can a care manager help with like a sick cardiology patient and actually help the specialist as well, that's very informative to them. All right, switching gears, John, we have talked about your wrapping infrastructure and informed care coordination tools, analytically informed care management around physicians. Like, let the doctors do their thing, let them take care of the patients and surround them with that infrastructure. Tell us a little bit more about how you've gone about that over the years.
Sure. Got in the primary care business 20 years ago as a staff model, pretty much coming out of the HMO industry, saw the need for primaries to have more infrastructure and support to manage their panels more effectively. And, that was in the time frame when fee-for-service reimbursement was dropping, and there just wasn't enough time in the day for primaries to see patients, manage infrastructure, and make a living. So the idea came to create a staff model and build the infrastructure around. So we were one of the early adopters of chronic care management back in the early medical home days. We tried around with third-party analytics and started building our own in-house analytics. And it was really helpful to tie risk stratification that comes through claims data and EMR assessment data, tie those together and push out schedules to the primaries for the rising risk cohorts. So we really continue to focus on that. We think that's been a hallmark of our success, is to we do manage acute and post-acute spend, but I think we really do a lot more in the total triple aim, quality of care through prevention, identifying rising risk profiles, and really managing care plans to those profiles. And the primary care has really adapted to this process. And the staff model for us has been an incubator for a number of years. And as we brought on, IPA members, MSO members, other medical groups, they have their own cultures to work through, but we've been able to refine these processes so that by the time it gets to them for implementation, it's all the bugs have already been worked out.
Yeah, and we were talking before we turned on live on the webinar about the ease of doing this work in a staff model environment where not only I guess there's two things. One is, are the physicians employed or independent? But the other is, are the physicians working in like a single care model? Or are they trying to do this two ways? Like, over here's my fee for service practice, where I have care coordinators and where I may not have that. And over here's my like risk-based practice. And particularly as you get into these models where full risk is being taken on. I'd love to hear your thoughts on that. Like, what does it take to be successful? Like, is it a spectrum where you can do a little bit in sort of an independent practice that's still doing fee for service mostly, versus sort of all the way up to the fully employed, only one population of, full risk care model?
Right.
John, we'll start with you on that.
Where our goal is to get cap payments on primary care and never have to see the patient, right? That's the ideal, is to grow the physician panel, from 400 Medicare lives to 1,000 Medicare lives and not overwhelm them, because the management team kind of carries over all the surveillance work. So you really can grow the panel, and under a cap model, if you're paid PMPM, then the name of the game is to get more lives under management. So depending on which physician sees the end game, you have varying levels of engagement. And so but I'd say overall, once they get those checks, and they start seeing the dividends on the backside for very little levels of engagement, now they start getting much more aggressive in terms of how to even get more engaged. And but admittedly, it takes that first level of compensation for it to be real to the doc. And then we're talking about the specialists. It starts to bring the specialists into a level of engagement too, because they see the primaries are excited. They realize that there's value in this model, and they get more inquisitive about how to be a part of it. So it's been an organic process for us.
Mm-hmm. Yeah, I mean, my view has always been, you're not, I don't know what the number is, but like, what's the number that it takes to sort of prime that pump and get the attention of a physician? For primary care, 10 grand that's real money. Yeah. Right? But if you tell an orthopedic surgeon, if you completely change the way you practice and don't do like all this stuff, maybe we'll give you a check for 10 grand. They're not too impressed by that usually. So it really is more on, the volume side of the being preferred and being sort of a part of that integrated care team to keep the faucet open, frankly. That's how, they get more engaged. That's just been my experience. Rachel, you have a couple of different ways that you engage physicians. Tell us, what's your viewpoint on sort of this very intense, you have these like, I don't want to call them concierge, but tell us about like your practice model that is very, very different from like the usual way of practicing, but you also have a range of types of practices that you work with.
So we have an employed or staff model physicians, as well as the contracted affiliate side as well. And I think, John's right there, showing them some sort of monetary, dividend, bonus payment, something along the lines of that really, or surplus payment really gets them to get more engaged. We try to help the physicians as much as we can until they actually are there and they see kind of the understanding of, if I can do this with the patient and it results in a you know, an admission saved, then they're going to keep doing it more and more. And so, you know, at the end of the day, it really becomes the patient focus, that if they can, you know, really focus on that patient and get the care that they need at the appropriate setting, then they will get to that surplus or bonus payment. And I think from an employed side, we actually require all of our physicians to give out their personal cell phone numbers. And so to your point about concierges, it really does become a more of a concierge feel, that they can call the physician directly. They don't have to go through an answering service. We also have an answering service as well, just in case. But it allows them to go directly to the physician and not feel like, am I going to get that call back? Is it going to be in 5 minutes? Is it going to be in an hour? And they're getting directly to the physicians. And so that has really helped, you know, kind of that patient-physician relationship. And surprisingly enough, that most of the patients still go through the answering service, because they feel that security that they, if they had to, they could call the physician, and it doesn't result in like physician call, you know, getting calls all the time for nonsense things like, you know, a quick refill. I have 30 pills left, but I need, you know, a new refill's coming up soon. So they really get the focused calls that truly make a difference versus the non-urgent calls. And so it really has helped our employed physicians to be able to do that.
But that's a totally different mindset to practice in that model. And it requires a leap of faith. It's actually, you know, hard to find people sometimes who, that's not how we've been trained as primary care physicians for the most part. So interesting. Rick, Privia has all kinds of ways of engaging physicians. What's your thoughts on sort of the spectrum of, you know, straight independent practices that are still mostly sort of fee for service based, all the way up to like these sort of very custom concierge-y, you know, senior services, high risk elderly programs, et cetera?
Well, I think you know, first principle is this is U.S. healthcare, and so there is no one size fits all model. Patient preferences also are vast. Patient needs are vast and complex, and so I don't think there's. I think a vision of a single best model is a bit of a false mirage. You know, and I think it's good to see sort of these multiple type of models crop up, where you might have a kind of intensive clinic that is working with a specific niche population that can really serve their, you know, special needs. You know, so I think there is a place for that. And also, I think we found at Privia that, you know, the existing provider, you know, ecosystem sees a whole mixture of different patients, from commercial to Medicare, Medicare Advantage, Medicaid. And very rarely is there just sort of a one-dimensional panel that any provider works with. And certainly then on the reimbursement side, right? You were mentioning that, you know, fee for service or value-based care. I think it's a little bit of a too black and white thinking to say, do we do one or the other? Well, the reality is, you know, you probably have to deal with both. Even if you want to move to value-based care, can you line up every single contract, you know, simultaneously to be the same structure as one another? Especially if you're over different lines of business like commercial, Medicare, and Medicare Advantage, right? So I think, you know, if you really kind of look at the way doctors practice medicine today in this sort of complex way, you know, you've got to be able to serve different situations. And so all that is, I guess, to say, a long way of saying, you know, we really support, you know, multiple models. We don't feel like it has to be employed or independent. You know, there are different circumstances, and you've got to be taking in consideration, you know, what are the goals you're trying to accomplish? What are the programs you're entering in? what is the maturity of the market or the provider group you're working with, right? Things might be very different in Florida versus, Virginia. So, you've got to take into consideration all of these things and be thoughtful on a local level to say, what is necessary.
So I'm going to throw one at you that I didn't prepare you all for. In thinking about, all of the investments that you've made, and whether it's data, sort of physician engagement network, if you were advising a group who was thinking about getting into, starting to move away from just straight fee for service and, for example, sign up for the MSSP program. So not in downside risk out of the gate. And we can talk about, like, must you have downside risk in order to be successful? I have an opinion on that. We can talk about that too. But what would you all say to someone, like, if you're going to get into the MSSP world and managing population health outcomes and accountable care, you must have fill in the blank. Like, don't even try it unless you have. There's so many pieces of the puzzle, but what do you think are really, foundationally critical? Let's see, Rachel. Who wants to answer that one? I'm throwing this one at you with no warning.
I'll take it. So I guess to Rick's point, there's no one perfect answer. I think it's going to depend on the practice, but I also believe that if at whatever you do, focus on the patient and the patient needs. So if that creates your need for data to do that, or your ability to go outside of the box and do something different, I think if you can really get the patient where they need to go and the most appropriate setting, meaning, like, if you normally send them to the hospital for something, is there another setting that can do it that is a less cost alternative? Is it an ambulatory surgical center or SNF, or can you do it at the house? Something along that lines, where getting the patient and the care they need at the appropriate setting.
Right, and to go back to your, am I muted still? To go back to your value story, I was thinking about that one of the patient that you arranged for twice daily IV Lasix at home through your home care partner. That's the kind of thing that I've seen so many communities throughout my career in different parts of the country where, like, the pieces are all there, right? Like, there are home care companies, most of them these days have some kind of, like, telemonitoring. There are capabilities in most communities to do some kind of home IV. And what's missing is sort of the knitting it all together, right? And having, like, a physician often who's willing to practice in that sort of, different mindset, or having an emergency department who understands, like, you can send a patient home to that, or even before they get to the emergency. So often the pieces are there, and it's sort of that mindset that's not in place yet, or the clinical leadership, or what, I'm not sure of. So Rick, what must you have? What can you not do without to succeed in this world?
Yeah, I'm afraid of copping out on this answer, but I kind of feel like the question is, like, how do you live a healthy life? And it's like, do you try and sleep? Do you try and eat well? Do you try and exercise? And it's like, well, it's actually, like, living a healthy life is all of the above. So I mean, let me cop out first, and then I'll give you a real answer second. The cop out is, I think you do need all of these different pieces in place to really be successful, especially on a sustainable basis or high performing. Like, how do you do this without the data? How do you do this without the technology? How do you do this with the additional support teams and expertise? Certainly, how do you do it with the leadership without the leadership? And there's more along the way, the contracting of the programs and looking at them and analyzing them. So I don't think that if you just do one of those things really well, but then none of the others, you can really be successful in this place. But kind of back to your question, I guess, trying to not cop out, I would say that just the leadership of the group, and whether that's physician leadership or just of the organization, is really critical to take that step. And I don't think you can get any of those pieces lined up, no matter what they are, or really even to recognize that, we need to actually build up those different capabilities, unless there is a leadership that says, hey, we need to do something different. We need to change the way we work. We're going to go in this direction. Without that, none of this stuff really takes off quite successfully.
Yeah, and I think an example of that, I mean, if I were asked that question, I would say access to primary care, right? If you cannot get in to see a primary care physician in a super timely fashion, like your value story, where it was even stuck together through partnerships and cooperation among your private practices, like you're sort of dead in the water to some degree. And some of that is like a leadership mindset in the practice of, no, we're not successful anymore just by having like every 15-minute slot for the day is full. That's no longer defines sort of the successful workflow of the practice. Success is that the people who need to be seen in person now, especially so these days, are the ones that are getting seen in a timely fashion, and that there are processes in place that are hardwired to get all that other stuff done. So, John, what do you have to have? Don't try this at home without fill in the blank.
We actually talk about this a lot in our management team as we expand and look at other territories and markets. And we take very much a market approach and try to make sure we understand the market and the barriers and the existing players, the VBC players. Are they real? Are they imitation? Are they serious about it? Do they really have internal built knowledge, or is it all third-party knowledge? What is the competitive posture of other aggregators in the market? So it's we wouldn't just go into any market just because we're trying to grow lives. I know there's a lot of aggregators that try to do that. I kind of reconcile that to the old PPO model back in the 80s versus the HMO model, which was much more market centric and community centric, and worked with a serious group of players from the get-go and invested capital to go deep in a market. So there's a lot of strategies out there, and we're seeing them all the time. And it's just, I'd say, are you really serious about being in the game, or are you really just trying to put a pole in the ground and say, hey, we're a VBC model? And I think sustainability is a big question right now. I mean, when we got into the industry early on, a lot of entrants came in and left, and they didn't make the investment, but they saw the money up front, and then they eventually got out. And so I think we're starting to see the market turn towards longevity, and I think it's not too late to get into the space if you're getting into it for the right reasons.
Yeah. So knowing your market and having that, and it's not a one size fits all, but knowing the market and where's the biggest opportunity. All right. I want to invite the audience. We're going to move shortly to Q&A. And so I'd invite you to type in to the chat any questions that you have. And while we're waiting for that, I want to give everyone a chance to just briefly tell me what your belief is on, must there be two-sided risk, significant two-sided risk, in order to drive success in these programs? Rachel, what are your thoughts on that?
I don't think you have to necessarily have every provider have two-sided risk. I think that as long as the providers understand the risk model and that, what the value-based programs are, I think they don't have to have, that downside risk. I think it helps, but it's not mandatory to make it successful. I think it also depends on the physicians or the providers as well, based on their individual practice.
Rick. two-sided risk must have?
Well, I think there's kind of two parts of that question. One is sort of, should the organization have two-sided risk? And I think the organization doesn't necessarily have to be in two-sided risk, although that's just where a lot more of the opportunities might be. We've been successful across a lot of different flavors of the spectrum, I guess. The second part is sort of, if you have two-sided risk, should providers take risk? And we do believe in having some skin in the game. We don't think that you should just fully backstop 100% of any downside. We think there needs to be some alignment in incentives across the organization. Now, that might not be unlimited, or certainly you try and keep it to a reasonable range, but that's how we view it.
John, must you take large amounts of two-sided risk?
At the provider level, no, absolutely not. It's how quick do you want to get there, and a lot of times you don't want to get there too quick. So if you're there and you have doctors that you model out and they can do a lot better on a CAT model, then absolutely go that route. But if you have doctors that are in that learning curve process, and there's plenty of ways to structure a compensation arrangement that gets them there. And I agree with both other panelists, not every doctor is going to be enthralled by taking downside risks. So there, the organization has a decision to make. Do you want to keep that doctor on your panel or not? And usually we've been able to move pretty much every doctor somewhere up the curve. So
that's great. And I'll just want to state my personal view and more the organizational level. I think a lot of folks have pointed to, the organizations that have been very successful are the ones taking a lot of two-sided risk. But my answer to that is, like, in a voluntary program, that's no surprise. That's like telling me that folks who are in the Olympics run faster than the high school track team. So of course, anyone who is brave enough to take like full risk, like Rachel, for example, knows they're going to be successful. So it's a little bit of a reverse causation. All right, Garrett, I want to hand it over to a couple of questions. Go right ahead.
Okay, very good. And these are in no particular order here. So for Privia, how do you empower independent physicians to see patients from another practice? Are you sharing savings with them?
Yeah, so we will follow attribution methodologies in terms of how, based off the program, like an MSSP, the patient should be attributed to the various practices. But I think sort of to the example I was giving before, it's really trying to create a spirit of partnership or community across independent practices. And I think a lot of the physician community, or you think of these independent practices, they've operated very independently and siloed for a long time, and don't realize that potentially they can lean on other avenues of support. And so we just try and create that connection across practices through the relationships. Like I said, we share records very easily. And so, we believe that, really thinking about the patient and serving the needs within our group, is the best way to go.
Okay, great. And we've got a lot of questions. And just so you know, we won't be able to hit all of these today. So if I don't get to your question, again, we will definitely answer it via email afterwards. So this one is for Rachel. I heard that you engage with your physicians and or providers. How do you handle providers that want to do it their way and don't want to get on board with your goals and ideas?
Time and more time to prove to them that value-based is the kind of the way to go. Sometimes, unfortunately, time doesn't hold true and it won't work. And if we're not aligned, then we part ways. But I think, you know, after kind of month over month talking with the physicians, it's the little things that they can do to see that there's movement. Like, so from a financial perspective, you know, ACOs, like MSSP or Next Gen, you're only getting a shared savings payment once a year. So what can they do right now to move the needle? And so kind of showing them little things instead of just always showing them about financials is kind of where we focus on, you know, seeing as many patients as possible, you know, from their panel, things like they can actually 100% control. Maybe they can't control patients coming in, but, you know, trying to get those patients in as much as possible. So things like that where it's more under their control versus a financial performance perspective.
Okay. Great. We'll keep moving along here. We've got time for about two more. Next question is, during the COVID, the physicians who were in full cap models did better sustaining their practices. Was that true of the panelist experience?
For our practices, yes, absolutely. They saw a steady cap coming in, and they could rely on that versus fee for service kind of dipping. I don't know if anyone else wants to jump in too, but we definitely saw that. Yes.
We were a little different. We had our cohorts identified, pulmonary, respiratory failure, and we just targeted those audiences during the COVID and really pushed their schedules, their interventional levels up. So we got them in to see the doctors on a more frequent basis, or home visits. We introduced virtual care, some RPM at the time. So we actually were not capped, but our access went up. So overall, the revenue went up as well.
Yeah, and I think quickly from our side, certainly I think value-based care created a bit of continuity and consistency for practices versus just pure reliance on fee-for-service. That's absolutely true. And I think just extending John's point, which I think is a really good one, is value-oriented organizations who've been doing the work over the last few years to build the infrastructure, patient engagement tools, you know, data, looking at data. Those organizations were better prepared to respond very quickly to the type of issues that cropped up. And, you know, how do you get a hold of your patients? How do you educate your patients quickly? How do you, you know, leverage technology in a very, very quick way? And so, you know, I guess selfishly, we're very proud of our ability to kind of respond, but a lot of the sort of pieces were put in place years before that moment of, you know, COVID happening before.
Okay. One quick question. This one's actually for Rick. How does Rick's group Persivia share the data on their preferred narrow network? Is this through website, white papers, etc.?
So we don't share the data internally, but so yeah, we have a sort of whole capability where we're pulling in all this outside data into a data warehouse. We have very smart people on our team who manage that data. There's anybody who's lived through this knows that there's a lot of inaccuracies and issues with the data, but we bring all this data in. Like I said, we add a bit of clinical input, and then we house that referral tiering, that preferred internal network for our providers to make that more informed referral. So we're not publishing that preferred network externally or something like that today.
Okay. Next question is for Rachel. I'm very interested in how you tracked where patients were already going to inform preferred provider relationships. Did you further evaluate preferred providers on quality to inform the contracted rates or inclusion into your network, or did you just fully rely on the pre-existing relationship?
So what we did, we had been in NextGen for 2 years before we went to the claims payment. So we had all the NextGen data, CCLF files. So just worked through claims to understand where the patients were going and reached out to the providers. We did not look at data with regards to like the contracted amounts. We kind of let the providers steer that because we didn't want to be too hefty, but we didn't want to also be too low in the ask too. So we also looked at other health plan networks to see where specialties were contracted among in the area of that we were talking to those providers. So if like a health plan was normally at 90% of Medicare, we kind of had that as a starting point as well.
Okay, great. So the questions are rolling in, but unfortunately we are out of time. So please keep asking your questions. We will get to them now. And I just had this thought. If you out there think, you know, this is awesome, we would want to hear a part 2 to this conversation, let me know. And we'll see if we can put that together. But I wanted to, as we conclude here, there's a couple things that I wanted to bring to your attention. And first, I'd like to encourage you to visit the Care Journey exhibit booth at ACO Exhibit Hall. And this is where you can learn more about them and connect with their team. And this is also where the recording of today's session and the slides will be available for download. You can get those in our library at acoexhibithall.com. And so as I say that, thank you so much to our speakers. You guys were great. You know, we really enjoyed that. And for our attendees, I have 2 very short questions that I wanted to ask you. And these are, the first has to do with your experience today. And so I'm actually going to pull this little poll up here. And it's just a really quick multiple choice question. So take a second and ask this if you would. And this just, again, kind of gauges us if this is something that you really liked and would want to hear again, put, you know, at the top. If you have specific comments that you would like to give, unfortunately, I don't have the ability for you to write in specific answers, but feel free to contact me via email, and you know, we can certainly do that. As you're filling this out, the next question that we're going to ask, and this actually gauges us to let us know, or Care Journey, how to follow up best with you, if that's something that you would like. Care Journey is offering a complimentary one-on-one session with its data experts to show you market and competitive intelligence in your region. And if you'd like to take advantage of that, select yes to this next question. So I'm going to close this one out. And then I'm going to do this next one here. All right, and again, if not, that's fine. But if you would like to have someone reach out to you, then go ahead and click that. And while you are doing that, I'm also going to put on the screen here the contact information. If you would like to reach myself or any of the team, or the panelists for further questions or discussion, you know, please do that, and their contact information is up here. So thank you all for attending so much. I appreciate your time. There's a lot of stuff vying for your attention right now. So you joined us, and that's of great value. So hope that this was a very informative session for you, and thank you again to our panelists and to the Care Journey team. And feel free again to reach out to any of us if we can be of help. So thank you so much. Have a wonderful rest of your day. Bye-bye now.